Welcome to Cardiology Grand Rounds. We're going to try to start right on time today and have a very short introduction of our speaker because he is well known to virtually everybody who is on the line today. Kelley Branch was born in Utah, but spent very much of his early life in Southern California, including his undergraduate work at both UCLA and at UC San Diego. He went to Jefferson Medical School, and when he came here, he got his MSc in epidemiology. His postgraduate training included residency training in internal medicine at Michigan and his fellowship here in cardiovascular disease. And above and beyond that, he was an ITHS KL2 research scholar for 5 years. For those of you who do not know this is really, in my view, more difficult to get than a K23. I'm sorry, K08. And he started his faculty activities here in 2004. And he became my associate director in the clinical trial service unit in 2012. He initiated and started the cardiovascular clinical trials unit in 2014 and became full professor in 2020. I'm sure one of his most important accomplishments will be for you to know that he was one of the founding and is present board member for the Society of Cardiovascular Computed Tomography. His continuing special local responsibilities include he has been an applicant interviewer for the KL2 and in 2016 became part of the selection committee. For those of you who are interested in his publication record, he currently has 92 publications with, 8 or 9 more on the way. Now, the reason for him giving grand rounds today is he's taken on the unenviable task of reviewing the newly published guidelines on chest pain, the chest pain update, and this now has been approved by the AHA and ACC, and I believe also the ESC. Now, the reason that it's appropriate for him to do this is because he was asked to be one of the reviewers before it was published. So without any further ado, Professor Kelley, please take us through your talk.
Great, thanks, Jeff. Thank you for the very nice introduction, and it's been a wonderful travel that we've done together through the clinical trial service unit. So it's my pleasure to talk about the chest pain guideline, and as we know, these were slightly delayed in coming out from the AHA and the ACC and multiple other agencies, and really only came out last week. Although I was planning on having the slides a little more time to prepare the slides, but the other thing I wanted to do is also to tie it in with some interesting data that is guidelines specifically coming out of the European Society of Cardiology as well. So without further ado, let's go ahead and launch in. And you can see here my financial relationships and disclosures. None of these are really pertinent to what we're going to be talking about today. So we'll talk very briefly about the quote-unquote chest pain introduction, and then really dive into the guidelines for chest pain, both the AHA, ACC, as well as some of the newer ESC guidelines, talking specifically about some of the patient history and risk factors, but really more about a lot of the changes for these documents, talking about the probability, the pretest probability of coronary artery disease and ischemia, the types of patients that we're looking at, and then really a lot of time really on the evaluation, because that's really what this document is focusing on, as well as a very, very little on treatment. And then talking about some of the unmet needs, future directions, and really what we're going to be talking about when we're talking about chest pain is a chest pain syndrome. And that is that it's not just chest pain. It is more than that. It could be dyspnea, it could be other symptoms. And then we'll break it apart into whether or not it's new or stable and whether or not there's pre-existing coronary disease or not. So I think everybody on the call knows that when we're talking about cardiac imaging, really what we would like to know are a number of things. I mean, obviously we'd like to know what the morphology is. Specifically, we're talking today about the coronary arteries and myocardium, but other vascular structures and valves as well. But then also the physiology. So is there ischemia, and then anything else that's pertinent, such as velocity and pressures, and then of course prognosis, which is a risk assessment and treatment. And then really what this comes down to, though, is what do I want to know? Well, depends on whether or not my patient's asymptomatic or symptomatic. If it's either, I want to know if there's coronary disease at all. And then if there is, how should I be treating my patient differently? And the symptomatic patient, which is what we're going to be focusing on today, if the patient has obstructive disease, I want to know whether or not it's caused the symptoms rather than true and unrelated. You want to know the extent and severity of ischemia to make some decisions about what you're going to do. What's the anatomy and function, again, the morphology, and then, of course, prognosis and what can be done in order to improve said prognosis. And so really, we're going to be looking at 3 different guidelines today. The far left is the new ACC AHA guidelines. They still have that new guideline smell since they've only been out for a week. And then 2 guidelines which have come out in the last 2 years from the ESC, one of which on patients with ACS without persistent ST segment elevation and patients with chronic coronary syndrome. So just so you know, the scope of work, there are 247 pages to review, 35 tables and 37 figures. Note that we will not be going through all of those, and you can thank me later for that. So I've tried to distill them the best that I can, and so we're going to try to squeeze out as many high-yield facts as we can out of this, but just knowing that we are not going to be able to get to it all. So I'm going to be talking about some of the strength of recommendations and level of evidence, because I think it's important just to know when smart people are making these decisions, it is a committee and they say, well, you know, how strong do we think the level of evidence is? And if it's green, that's a class 1. If it's yellow, it's a class 2A, and that's moderate, that's pretty good. 2B is pretty weak. And then if you have all the way down to the red, then it's strong that we should be doing the opposite. The risk is greater than the benefit. And then the various blues show the level of evidence A, it's very, very high quality, usually 2 randomized trials, and then all the way down to CEO, which is expert opinion, which is really the, unfortunately, a lot of what medicine is kind of the art of medicine and what we think. So we really try to adopt the guidelines based more on the stronger level of evidence. So one of the things that the guidelines decided to put together was this kind of cute, I think it's maybe a little trite, take-home messages under chest pains. And one of my colleagues quipped that this was an AUA, which is another useless acronym. But suffice to say that there are specific parts of it that I think are important. I'm not going to go over it now, but I will go over certain parts of this as we move through the presentation. So let's talk about what some of the key points are, and we're going to keep coming back to these as we move through the guidelines. So what were some of the key points? Well, there's a real emphasis on pretest probability. And how do we do that? Rather than using our gestalt, the suggestion is that we use structured risk assessment and clinical decision pathways in order to move forward for our patients. So really putting more quantitation rather than our qualitation, which is what we have been doing. We remind ourselves of the chest pain as really a chest pain syndrome. This was the only thing that I was overruled on, is that I said maybe we should call it a chest pain syndrome or other moniker, because there really can be other symptoms, but they suggest, well, chest pain is not only chest pain. And nowhere is this more evident in women, where even though chest pain is most common, there are other symptoms, and they list those symptoms as well as the elderly, which may not be just strict chest pain or chest discomfort. The other thing is that we are going to be moving away from atypical chest pain and really trying to move towards cardiac, possibly cardiac or non-cardiac, and really trying to get rid of the atypical moniker, which means we're going to have to do some changing in some of our algorithms. For patients with really low pretest probability, and that is a less than 1% of major adverse cardiovascular events, or MACE, you stop there. And that's really all that we need to do. We can discharge, we have the option of doing additional studies later on, But with that really, really low pretest probability, the idea is that you can stop there. In some patients, we can get a coronary calcium to risk stratify further for treatment as a level 2A. But for patients with ACS, less than 1% MACE, we stop. In addition, they've suggested that we move to high sensitivity troponin rather than the standard troponin assay, and I'll talk about that. One of the other moves, which has really actually come together as far as the European Society of Cardiology and NICE in the UK, is that coronary CT angiography has finally gotten its due, and it's now a level 1A and can be a first-line evaluation both for stable and unstable coronary artery disease. And it's really now equivalent to stress testing, which is also a level 1. Of course, there are some caveats. Patients with known obstructive coronary disease, now with an age cutoff of greater than 65, irregular rate or patient motion, those would be times when stress testing would be preferred. But if you do a CT angio and then there are abnormalities, specifically obstructive coronary disease or the scan is not evaluable, then you can add on either an FFRct if you can see the obstructive disease, or move to stress testing. What we're going to find out is that there's a dichotomy in all of these evaluations, whether or not it's morphologic or physiologic, and that is split up into normal or mild versus moderate or severe, and those are really the branch points that you're going to see for all of our further tests. Finally, for invasive angiography, that's really going to be now relegated to those with ACS or post-test, and that can either be a post-test, pre-test probability, or a post-test after testing. Those patients are deemed high risk. So those are really the key points, and I think wanted to spend a little bit of extra time going through those, and now we're going to see how these manifest through the guidelines. So let's take our patient. This is a 62-year-old female who presents for new chest discomfort for the past week and comes to the emergency room for evaluation. She describes it as a mid-sternal pressure. She has no exacerbation with stress or exercise, but she says it's a lot better with rest or relaxation. She also notes some dyspnea along with this, but really no other symptoms. Past medical history you can see here, both hypertension, dyslipidemia, and some remote asthma. Is currently taking aspirin, losartan, and low-dose atorvastatin. The physical examination is unremarkable, and the ECG is essentially normal. So for this patient, they're going to fall under the newer acute chest pain syndrome with no prior coronary artery disease. So how do we approach this patient? Well, we're going to do the things that we've always been doing. And you can see that what we're going to be doing to the left and over to the right are the level of evidence for both the acute coronary syndrome evaluation or chronic coronary syndrome evaluation for each one of these. And obviously reviewing the type of chest pain symptoms. What does it feel like? You know, is it pain or pressure? What are the associated symptoms? All of those things are, of course, level 1A, not too surprisingly. Then we go and we start talking about past medical history and risk factors. And really what it comes down to is trying to calculate a pre-test probability. And that is also level 1 through all of these guidelines, not too surprisingly. For our patient, the patient undergoes acute evaluation. That can include a chest radiograph. It includes an ECG and, of course, a troponin for the biomarker. And that is really just the standard of what we do. Well, in the new guidelines, remember, we're moving away from atypical. They've talked about the chest pain descriptors, and those are over, and you can see that there are priorities as far as the probability of ischemia, those that look like they are high risk versus those that they are low risk. And for our patient, patient describes a pressure, so that puts it at low risk, but it says it is not exertional and stress related. So it still falls into that possibly cardiac evaluation, but don't call it atypical. That is now out, so we're going to strike that from our vernacular. Now, what about specific populations? I talked a little bit about that in the high yield facts, but for women in the middle here, remember that chest pain is still the most common presentation, occurring well over half of the time, as opposed to about 77% of the time for men. But also there's an increase in palpitations, jaw, neck, or back pain, and accompanying symptoms. And the guidelines now suggest that, of course, chest pain, it means more than pain in the chest, but talk to them about the symptoms. And once they have more or 3 symptoms or more of either radiation, of epigastric symptoms, dyspnea, nausea, or diaphoresis, then those patients are at higher risk, and that's part of the A, or accompanying, which is women may be more likely to present with accompanying symptoms. So this is pretty much what we're doing already. Now it's just really manifests in a guideline. For those greater than 75 years, again, chest pain is most common, but other symptoms can be a little more prominent, such as dyspnea, unexplained syncope, unexplained delirium, or an unexplained fall. Any of those in someone greater than 75, we really should be considering more of a chest pain syndrome. And then, of course, ethnicity, there are varying symptoms, and so through various ethnicities, and so suggesting that cultural competency training be done to try to recognize those. So now if we look at some of the graphs which are put together, and they're all very colorful and very interesting, trying to get to the pretest probability, just talking about what we did. Well, we took the history, we took a physical examination, we did an ECG, we did a clinical assessment, and now we're going to get a troponin. And again, all of this is heading towards a pretest probability. But let's talk a little bit about troponin, because that's going to be really one of the forks in the road as to how aggressive we're going to be with our patients. And we talk about high sensitivity troponin versus the really standard troponin. On the higher levels, basically the troponin levels are identical. There's just about 1,000 difference. So if you went from a high sensitivity assay, which is in nanograms, you can just convert it to a conventional assay pretty closely just by multiplying by 1,000. Where high sensitivity troponin really works is because it differentiates the normal from the mildly abnormal at the lower levels of troponin, and really getting away from a gray area. And this is a lot of times that we, we'll waffle a little bit. What does this mean? Type of a thing. High sensitivity assays takes that away by increasing sensitivity at the expense of specificity, so more troponemia of these patients. Now, what is interesting is that we actually have high sensitivity troponin, so we do have the Beckman assay, but because of the confusion that goes along with now changing the numbers by 1,000, we still use a conventional assay levels at micrograms per liter. These reduce confusion. Just so that everybody knows, the 99th percentile of high sensitivity troponin is about 17.5 nanograms, or about 0.2 micrograms per liter. And so you can see why we would use a cutoff. Excuse me, it's supposed to be 0.02, cutoff of 0.03. So the AHA-ACC guidelines don't really talk much about this, but the ESC does give this some credence, and this is also a lot of what we do. So that this rapid rule out and using the delta troponin in order to try to help us out. Well, the high sensitivity troponin, again, is preferred not only in the ACC-AHA guidelines, but also in the guidelines through ESC, because if we use a high sensitivity troponin, we can use a delta troponin, that is a baseline, and then another one to see if it's rising within 1 to 2 hours, and 3 is kind of the maximum. If it's normal, then the patient can be discharged at that point, again, maintaining that very low MACE rate. If it's equivocal, then the suggestion is to either get an echocardiogram or do another 3-hour troponin, so at 6 hours. Using a standard troponin assay, the recommendations are between 3 and 6 hours of the delta troponin. But the idea is don't use CK and myoglobin anymore, really just be using troponin in order to make your decisions. So if we try to now incorporate all of this into a pretest probability, we're going to do something like this, and we can use these clinical decision pathways, and you can see many different types, and there are more than this, but this is what is actually listed. And it is suggested that we now move to this, and we have the HEART pathway, which is used here. There's EDICS, ADAPT, NOTR. There's an ESC using troponin and ESC grayscale, and you can see all of the different populations, all of the different variables. If we then go to what's low risk, intermediate, or high risk, all of these things, it really actually becomes rather confusing. But really what it comes down to is trying to do this in a quantitative way in order to translate to something that is going to be a little more qualitative, and that is low, intermediate, or high risk. And then based on that, actually making some decisions about whether or not we should go down 2 pathways. But it really comes down to the risk of major coronary events determines the kind of testing that you are going to do, or alternatively, the lack of testing. So now that I've gone through that rather rapidly, I kind of feel like, oh my goodness, too much information, mind blown, right? So now we're going to try to take it for the next little while and try to take this into pieces, because I think it's the only way to really digest the guidelines rather than trying to see more and more and more and more. So let's base this off of figure 5. And figure 5 is this tiered approach to risk. And then you can see off to the left-hand side is the acute chest pain evaluation, the ED evaluation like our patient, and then over to the right is the stable chest pain or outpatient evaluation. So let's try to break this apart a little bit. So in our patients, if we find that they are low risk by our by troponins, it's low risk by our clinical pathways, at that point they can go home. And the suggestion is that there's no additional testing. In patients with stable chest pain, this is not our patient, but in other patients, then you can defer testing and you can think about doing a stress ECG or a calcium scan in order to look further. But at the low risk, they suggest the patient just plain goes home, and testing is really not needed routinely and really should be individualized for the patient. On the flip side, though, when do we consider going directly to invasive coronary angiography? And none of this has really changed all of that much, except for these high-risk scores. So if you have acute coronary syndrome that's troponin confirmed in the IE, that is an NSTEMI, right? Those patients should go to invasive coronary angiography. If they are newly reduced left ventricular ejection fraction that is unexplained, we should go to coronary angiography, or of course, if they're hemodynamically unstable, having other issues, cardiac arrest, etc. Those aren't too surprising. One of the changes is that by taking one of the risk scores and taking one of these, the HEART score is one, the TIMI score is the other, GRACE score is the other. And by doing these tabulations, we find that the patient's high risk, that's when we should be considering invasive coronary angiography directly rather than going through the other algorithms. Well, fortunately, it's really nice to be a little bit ahead of the times. And I'd like to thank my colleagues from emergency medicine and radiology and cardiology for all getting together and actually creating a clinical decision pathways called the UW chest pain pathway. This is available by going to Dr. Google, typing in UW chest pain pathway or UW chest pain, it'll pop up. And then you can go through and do these things. And so for our patient that we were just talking about, on the left-hand side, we have the HEART score. And so so you can see that I started clicking these things, and we believe that the history is moderately suspicious. The ECG is normal. The age is greater than 60. She has 2 risk factors of hypertension and dyslipidemia, and her initial troponin was negative. And that switches her over and says intermediate risk. We click the additional risk stratification, boom, and we get our next view, which is this one. By adding some additional information as far as what the heart rate is, what the systolic blood pressure is, what the risk factors are, et cetera, we get a risk assessment of what the likelihood of having obstructive coronary artery disease and what the GRACE score is. And once we put that together, we go to the next screen. It actually gives us a recommendation about what we should do. Fortunately, these align relatively closely to what the guidelines say, actually very, very closely. And so in this case, for our patient, based on risk factors, based on everything else, coronary CTA was the recommended test, although we had many other alternatives. But really what it comes down to is our patient is intermediate risk. So now what do we do? And then based on our triangle of confusion here, we now either choose anatomic or functional stress testing for our acute chest pain patient, and really the same for stable chest pain. There's really not much difference. So now we go to this next figure, which is the evaluation algorithm for patients with suspected ACS with intermediate risk, but no known coronary disease. Now, whenever I pull these up, right, the first thing that you look at is just a lot of boxes, and it kind of reminds me of actually trying to translate the matrix a little bit. I think the only way to do it is to try to break this down, because if we can figure this one out, then we can figure out all subsequent algorithms, because they really are very, very close. So if we look at both the AHA, ACC, and the ESC guidelines, they're relatively close as far as what we should be doing next. And so for patients with intermediate risk and suspected, otherwise known as other and the ESC instead of very low versus high, then we can say, well, we have a choice of either going down one of two pathways. For the ACC on the left, we can either get a coronary CT angiography. Otherwise, we can go to stress testing, and we really have our choice of all these different modalities, and both of these are level 1. This is also supported with the ESC, and basically the same thing, and that is they're intermediate risk. You observe them, you may get your rapid rule out, but trying to figure out what your disposition is, most of these people will either do stress testing, CTA, or consider for angiography. Well, let's take a look at how these actually perform. And these are from an older ESC guidelines, and these are stable coronary disease. So these are slightly different for acute coronary syndrome, but we kind of get an idea about what the sensitivity as well as the specificity is for identifying coronary artery disease. And this is slightly different if we're actually looking for ischemia using something like fractional flow reserve. But suffice to say that exercise ECG in the dark blue has always been one that's performed rather modestly. And if you take out a lot of the bias, you can see the sensitivity for this test, which is widely used. It's actually very, very poor, and it's even worse in women. Once you add on imaging, then you can see that they kind of warble along, but most of them actually do relatively well. The best in general is vasodilatory PET. I did not put in CMR, and I apologize for the omission because that has also been shown to have a very high both sensitivity and specificity. So really PET and stress CMR are really the highest diagnostic accuracy. The reason why CCTA is actually done really well is because if you look at the sensitivity, it's actually incredibly high, and it's actually the highest for any of these non-invasive tests. And so it has a very, very strong ability to rule out coronary artery disease, and I think a little more modest ability to rule in cardiac disease with the specificity over to the right. Not too bad, but it's really the sensitivity that is the driver for using that specifically. But how do I choose? And so we get a lot of these things. How do I choose? Well, I can go either to the guidelines, and I can take a look here, and I can look at my pretest. Well, I've got intermediate risk, and so if my patient's young, or my patient's it's suspected that they have less obstructive coronary disease, then CTA is preferred. But if they're older, or we really suspect that they're CAD, then maybe stress testing. Well, we can also use the guidelines, the clinical decision pathway, such as our tool in order to try to help us out, because we have put in a lot under the hood as far as what to choose based on whether or not they have some heart block or left bundle branch block, or whether or not they have an iodine contrast allergy, et cetera. But the guidelines say that really the decision should be based on local expertise and availability in your center, because if you don't have someone who is very comfortable with CCTA, or you don't have availability at all, well, obviously stress test is what you're going to do. So let's break this down a little bit further, and I'm going to put this into chunks. And then you really fall into one of two categories. Either we're going to do a stress test or a cardiac CT evaluation. And for the CCTA evaluation, this is actually very, very similar, whether or not you have coronary disease, no coronary disease, a prior evaluation, et cetera. It's pretty much the same. And so what it comes down to is you get your CCTA, then you take a look and you say, well, is this obstructive or not obstructive, right? And it's either normal or mild, i.e. non-obstructive. Remember the dichotomy, normal or mild. That's less than 50% stenosis. Then those patients get some guideline-directed medical therapy. There's coronary disease in general, we'll put them on statin and think about an aspirin and discharge them. If it's inconclusive or obstructive, at that point, they get guideline-directed medical therapy as well. And generally we move to further testing. And that is that if they are normal or mild, right? Then those patients will go to guideline-directed medical therapy and get discharged. We see that down at the bottom. If the patients are moderate to high risk, and that is to moderate severe ischemia, or have an FFRct, which is another option to use, and we'll talk about that in a second, then those patients should go to invasive, or at least be considered for invasive angiography. If they are high risk based on the CCTA, and that's defined as a greater than 50% left main stenosis, or those patients with greater than 70% coronary artery disease in 3 vessels, a CAD-RADS 4B as we call it, then those patients should also be considered for invasive angiography. Now, where does this come from? How do we get a level 1? How do we get a level 1A? Well, because there are a number of randomized trials, and these are kind of the big 4, but there are about 6 or 7 that are out there: CT Stat, ACRA, and RomaCat, and one that I'm the senior author for, which is CT Compare. And you can see that these were done at various sites. The pretest probability tended to be low to intermediate risk. And really what it came down to is we look at the length of stay, the 30-day MACE rate, and the cost is that coronary CTA ended up being faster, it was cheaper, and it appeared safe as far as the major adverse cardiovascular events. And so because of these data, this is really what was driving the guidelines here, was really the overwhelming evidence in multiple randomized trials giving it a 1A recommendation. Now, the other thing that comes out, which was really not featured quite as much, but mentioned in the guidelines, is that the normal to mild area also gives information. And that is that if you looked at patients that had any coronary disease, right, those patients with non-obstructive disease, that's in the pink line, versus the patients with one vessel obstructive coronary disease, you can see that they were basically the same as far as major adverse cardiovascular events over time. And so that just the presence of seeing coronary artery disease actually informs major adverse cardiovascular events going down, similar to what we see with obstructive coronary disease. And so by seeing some of that, the patients really become what I call a primary plus or a secondary minus, and patients should be treated aggressively to prevent downstream MACE. And because non-obstructive coronary disease really is still significant. This is manifest in the CAD-RADS reporting system, and so you will see this when you get your CCTA report. Ricardo Curry did this, and the CAD-RADS 2.0 is actually in a kind of advanced stage of development. But essentially, it says that if you are a CAD-RAD 0, you have a very, very low ACS risk. So these are no stenosis whatsoever, so normal coronary arteries. ACS is highly unlikely. Those are the patients that go home. Well, in addition, those patients that are low risk, and that is less than a 50% stenosis, the ACS risk is actually really quite low. Those patients can be discharged. However, their risk over time, over the years of major adverse cardiovascular events is increased, and so they should be treated as such, but treated really as an outpatient. Once we get to a CAD-RADS 3, which is a 50% or greater, at that point, they have both an increased risk for ACS and an increased risk for MACE. This is the moderate to severe dichotomy, and those patients should be generally admitted and considered for further evaluation and or therapy. But when we talk about CTA, you'll notice that the fractional flow reserve CT is actually a 2A recommendation. It's actually lumped with additional stress testing once we have obstructive coronary disease. But what is it? What is this fractional flow reserve? And I know that the cardiologists know, but we have many others that do not. And so let's review this very, very quickly. So what is FFR? Well, FFR essentially, and this is invasive FFR, it puts a wire down a coronary artery and then measures the pressure distally to see whether or not there are actually a decrease in pressure from proximal, generally the aorta, to distal to a stenosis. And so you can have a pretty significant stenosis and at rest have a similar coronary pressure, and you can see the pressure wire sitting in the coronary artery and then the lower level sitting distal to the 75% stenosis. But once you stress the patient, generally using vasodilators at that point, then we see something very, very different, and that we see that the flow increases, but the fractional flow reserve, and that's the ratio of pressure proximal to the ratio of pressure distal, actually can change. And you see in a normal coronary artery, then they can change a little bit, but they're pretty darn close. But you can see a significant drop in the green distally as opposed to the proximal pressures. And this ratio, called a fractional flow reserve, and in this case came out to 0.69, which was less than that threshold of 0.8 or 80% ratio. That is significant and moves us into the moderate to severe ischemia, and more evaluation should be done. Well, the principles of FFRct are very, very similar, but instead of using physiology with wires and stress, we actually use morphology in order to try to do the same thing. So we create a 3D anatomical model. We then, right now, there's really only one vendor that does this, HeartFlow. So we send this to them in Palo Alto. They then do a physiologic model of circulation based on isolation of the coronary arteries, do some boundary conditions. We have some assumptions as far as what the microvascular resistance is, and then you compute coronary flow, and you get these very, very pretty vessels as such. And it really simulates blood flow. It simulates what the fluid dynamics are, and really tries to create, again, a fractional flow reserve, and you can see the numbers there based on morphology. If we look at how well this performs, it actually performs fairly well. I'll show you really the best data that are out there for FFRct, and that's the Pacific trial, which is, of course, only could be done in Europe, where the same patients underwent fractional flow reserve, positron emission tomography, already had a cardiac CT from which the FFRct was derived, also did SPECT, and you can see that doing a receiver operator curve over to the right-hand side, that fractional flow reserve calculated from cardiac CT actually at the highest area under the curve. And so based on these data, it was thought, well, this is actually pretty good, but how well does this perform? And you can see that it actually performs relatively well. There's actually a large splay between for specificity, because that's really where the strength is going to be. The sensitivity is quite good for CTA, thank you very much, but the specificity is better. Now, remember I said that these are based on stable disease, stable coronary artery disease, and that's what the Pacific trial was mostly the same. But really what it came down to is that the specificity, as we get more and more disease, goes down and down and down. So what we see is there's an incremental benefit of FFRct from these patients that are significantly diseased. And so that was one of the reasons why it actually moved up into a 2A. Well, now that we have gone through our CTA, what about the stress or physiologic evaluation? If this is what you have, this is what you'll be doing. And you really have a choice now between either doing a stress first rather than a CTA, or doing a CTA, and if that's abnormal, we can add on stress testing for further evaluation. You can see the level of evidence over to the left. And so what are some of the issues that occurred with this is that based on this evaluation document from the AHA-ACC is that all stress tests were lumped together, and that included exercise ECG, something that some of us object to a little bit. But suffice to say that there are many, many choices. The problem is the selection of stress wasn't really specifically outlined, and that was actually left up to us. Now, by using something like the clinical decision pathway that we have, that we've developed, can actually help you out. Otherwise, you can go and watch another one of my lectures on how to select the right chest pain. But oftentimes, it may even take a call to your friendly and nice cardiologist who will help you along as far as what was most appropriate for your patient. Once we've made that kind of a decision, again, finding that normal, mild, in this case, negative or mildly abnormal over to the left versus moderate to severe, inconclusive, those are the patients that will dichotomize from discharge to moving forward more to invasive angiography. The direct quote I've shown here, and really what it comes down to for intermediate risk patients with acute chest pain, the decision to use one versus the other, either stress test and or CTA, should be guided by local expertise and availability. And so basically was hand waving a little bit and said, you can kind of do what you want. So now that we can update this as when to send to invasive coronary angiography, we had what we had talked about before as far as high risk, but now we can add on to say that there's also high risk coronary artery disease from CCTA, and that is that left main stenosis of greater than 50% or 3 vessel coronary disease. Those patients with new to moderate severe ischemia on a stress test, or patients with a recurring angina, those patients should be considered for invasive angiography. Now, here's the interesting thing. What is moderate to severe ischemia? It's actually not defined specifically what is in the guidelines. And so a lot of the data that we based this on was the ischemia trial. And so what I did is I went into the ischemia trial and said, how did they define it? And this seems like a reasonable way. So if you have a nuclear test, either a PET or SPECT, and you have greater than 10% ischemic myocardium, though it's considered moderate or severe. In echo, if you have greater than 3 segments, greater than equal to 3 segments of ischemia, if you do a stress MR, greater than 12% or greater than 3% of ischemic myocardium, or if you do an exercise treadmill, greater than 1.5 mm ST depression and greater than 2 leads. or 2 millimeters ST depression, a single lead at less than 7 mets, so very low exercise tolerance. Of course, ST elevation, not mentioned here, but would also likely get you to the cath lab. Now, what happens if our patient comes back? Because patients do come back, there's recidivism, definitely. And if patients come back, there's a warranty period. And based on the guidelines, we have 2 different warranty periods. For angiography, and that's coronary CT or invasive coronary angiography, if it was normal within 2 years, your patient can discharge. It is highly, highly unlikely that the patient will have developed obstructive coronary disease over 2 years. For stress testing, however, the warranty used to be 2 years based on Workhomovich's data many years ago, but according to the new guidelines, the warranty is only 1 year. If you have an inconclusive test, either a CTA or an inclusive stress, then you can do additional testing, either stress testing for angiography, or if you do stress test first, you can do a CCTA as kind of the tiebreaker. But in patients that are high risk or having recurrent pain, or patients with moderate to severe ischemia, it is suggested that we move to invasive coronary angiography for further evaluation and possible treatment. Now let's come back to our patient, and then we're going to add on something, because the clinical presentation is the same, everything else is the same. But now let's say that our patient had about a 50% mid-LAD stenosis on a CTA done about a year and a half ago. Comes in with the same things, and now the patient has new chest pain, but does have existing coronary artery disease, even though it's not obstructive. So how does that work? Well, again, yet another guideline. Here we go. And it actually looks remarkably similar to what we had seen before. And we have the stress and physiologic evaluation over to the right. And then we have our CCTA evaluation over to the left. And if we compare what it looks like between the patients with prior CAD versus those with known CAD, they're actually very, very close. There's a few less boxes, but the idea is really basically the same. And that is that if you do a CCTA evaluation, if there's no change, that is kind of that normal to mild, they discharge if the patient has non-obstructive coronary disease to begin with. If it then has progressed, you can do additional testing and then decide whether or not they should get medicine and go home, or potentially go to angiography. To the right-hand side, if you do the stress testing, then you can, again, do multiple different stress tests. But you'll notice that there's one thing that is actually missing at this point, and that is there's no more stress ECG for those with prior coronary artery disease. So thank goodness we can get away from that and really be doing stress imaging to try to better evaluate our patients. The other thing that's interesting is that there's really no direct route to ICA, even patients with prior coronary artery disease, and those are the recommendations. Other than the high-risk coronary artery disease or frequent angina, we talked about that before. There's really, based on pretest probability, if you don't meet the criteria for high-risk coronary artery disease, frequent angina, then it is suggested you either go through CCTA for non-obstructive disease or stress testing, or for those obstruction, just go to trait physiologic evaluation. So to summarize, when we put this together for patients with no coronary disease or prior coronary disease, if you're low risk, the idea is that you can discharge your patients. The patients are intermediate risk. This is really the one you have to think the most about, and you can either do a coronary CT pathway or a stress testing pathway. And then based on whether or not it's mild or moderate, sorry, I should say normal or mild, or whether it's moderate or severe, then you either discharge with appropriate medical therapy, or you can move on to further testing. And in those patients that are the highest risk, think about invasive coronary angiography. Same for prior CAD, although there's also a warranty period for those patients. But a lot of it is that the guidelines have suggested that we should optimize medical treatment for angina first, the guideline-directed medical therapy first, and then consider moving forward. Patients that are high risk, invasive coronary angiography. So let's talk very briefly about some specific populations. I won't be able to get into all of them, but grafts for coronary bypass grafts were mentioned. And so I will say that for coronary CTA, they can be used for grafts. Grafts don't move. They're easy to image. They're usually relatively big. They're great. However, for native coronary arteries, it is suggested that we go directly to stress tests. So the reason being is that having done these over many years, there's an extensive amount of calcium, and you can see that. in the middle zone right there. There's extensive coronary artery disease. They're just really, really miserable to try to look at in the high likelihood of a non-evaluable segment. So in those cases, if you want to do it, either do stress testing, or if not, in patients that are high risk, or those that may have a non-diagnostic or equivocal stress, then going directly to invasive angiography seems reasonable. So what about alternative diagnosis? And obviously these are the things that we always worry about, and they can actually give a large differential, and I decided not to do it here just to save all of our eyes. And we all know this, that there's a large differential, but of course they mentioned that there are the common or the can't miss diagnosis of acute aortic syndrome. That includes aortic dissection, pulmonary embolism, myopericarditis, significant valvular heart disease, and of course microvascular disease, something that we're investigating more and more. So we talked about doing the CTA, and of course, could we actually do the triple rollout or the multiple rollout? One of the studies was actually done here early on, and there's actually really relatively little comments in the guidelines as far as incorporating those into the guidelines. A lot of the data shows that we should not be doing this routinely, and so the comment is that the general approach should be to use imaging protocols tailored to the most likely diagnosis, and that is using the multiple rollout of ruling out P as well as coronary disease, or dissection plus coronary artery disease. They really should be tailored to the most likely diagnosis first, and then in people that are truly equivocal, and this should be a minority of patients, then we can add on. Although there are a number of patients that get the CTPE, and then the next day we're kind of stuck to say, well, do we repeat it and do a coronary CTA now? So there are those options. So let's move for the last few minutes going into stable chest pain and chronic coronary syndrome. And let's take our patient and then now say, rather than it's 1 week, then she's having chest pain for a year, and that's really been pretty much unchanged, but wants that evaluation. And this is a patient with stable chest pain and no coronary artery disease. Now, what do we do? Well, some of the inference that came out of the ESC guidelines were that we have been actually hyperinflating the pretest probability of coronary artery disease. And I've been using this table actually for years over to the left-hand side, this historical data, and you can see that these were the likelihood of us seeing obstructive coronary disease for patients with typical, atypical, now we don't use that anymore, or non-anginal chest pain. And based on gender and then based on age. And you can see that those were hyperinflated and that anything over 50% we considered high risk. Well, using more contemporary data, you can see that there's actually a very, very low likelihood of those patients having disease, both in looking at kind of the way that we had done it with the Diamond Forrester, typical, atypical, non-anginal, and then the upper table to the right using chest pain and dyspnea. So we've really been hyperinflating, but one of the things that really kind of bore out was that most of the patients really are not high risk based on contemporary data for obstructive coronary disease. It's really the older men greater than 70 with more typical chest pain. So based on this, the ESC guidelines for chronic coronary disease said, based again on that pretest probability, doing all the things you had done before, assessing the pretest probability, using ECG, biochemistry, et cetera, all of those things. If the patient's very low risk, you don't do anything. If the patient's low to intermediate risk, then we can decide on whether or not to do cardiac CTA, and that should be kind of for on your lower risk side. Or if the patient becomes higher risk, then we should be testing for ischemia using stress testing, and only patients that are the very highest risk should be using invasive coronary angiography. And so they created these very nice bars, which actually tells you the clinical likelihood of significant coronary disease based on your test results, which I thought was very, very nice, showing the patients very low risk, that's 0 to 10%, and then the 50%, and then up to 90% they considered, 85% considered intermediate risk. But now you can see how some of these perform. The stress ECG performs rather poorly overall, which is why many of us don't like to use it. And then you can see how the other tests do very, very well, with coronary CTA doing quite well, as well as PET and CMR, and stress echo and SPECT also doing relatively well. But really what it comes down to is that nearly everyone has a pretest probability of 50%. And so based on these data, That's the reason why we're moving more and more towards doing initial non-invasive evaluation rather than sending more patients to invasive angiography. So here's the algorithm, again, looking at breaking this apart into a CCTA evaluation versus a stress physiologic evaluation. Very, very similar to what we had seen before, again, using that dichotomy of normal to mild or moderate to severe. Now, what are some of the changes that we had? Well, number one is that in the patients that are very low risk with stable chest pain, no testing is recommended, but if you want to, you can add on a coronary calcium score, which would better risk stratify your patient to more aggressive or less aggressive therapy, and you can use an exercise ECG in selected cases. But for most of the time, no further testing is recommended. Otherwise, we go down the same road. In addition, exercise ECG was downgraded to a 2A from a 1. And so in patients with stable chest pain, no coronary disease, exercise ECG is suggested to be a lower level of evidence, and stress testing with imaging should be considered further. So now let's take our patient. She presents with anginal chest discomfort for a week. She had a coronary disease. She had a greater than 70% stenosis on CTA. So this patient now changes to stable coronary disease because it's been unchanged, but also has coronary disease and obstructive coronary disease on a CCTA treated medically. Now what do we do? Well, the algorithm looks quite different in that the CCTA evaluation is approximately the same, but really most people are going to be, but the dichotomy here is whether or not they had non-obstructive or obstructive CTA. In our patient, we're going to be moving over to the right because she has obstructive coronary artery disease to begin with. And the idea is to intensify GDMT and the option to defer testing. Now, if we don't do that, then we assess to see whether or not the patient has high-risk coronary disease or very frequent angina. Our patient did not. That was a no. And so moving down to stress testing, again, exercise ECG is downgraded, but otherwise using one of those stress modalities, and then striking a balance between their normal or mild and moderate to severe. Moderate to severe should go to invasive angiography. In non-obstructive coronary disease, there's the, after intensification, there's the option to do CCTA versus stress testing, but suffice to say that, that many of those patients would get physiologic evaluations. In a minority of patients, and I'm not going to spend any time on this, the patients with frequent angina and then suspect that sound anginal but have no obstructive coronary disease, those patients might have small vessel disease and ischemia with non-obstructive coronary disease or normal coronary arteries, the ANOCA, or might have even had a myocardial infarction, so a MINOCA, a myocardial infarction. And then there are certain evaluations that can be done. I'll just note that these are there. Now, I've talked a lot about this, but really what happened to our patients? So as we're sitting there waiting at the Beckett and waiting for Godot at the Beckett International Airport, what happened to our patient? So our patient underwent cardiac CTA, and this is what we found. So these are curvilinear reconstructions of the LAD with the pointer there on the circumflex, and you can see this very narrow anatomy over to the left-hand side, and it appears that my media is not found, so it will not show this in curvilinear. So usually we can rotate the 3 dimensions. But suffice to say that this was considered a 80+% coronary proximal left anterior descending artery stenosis. And just to follow the guidelines, then we decided to actually do further testing. The patient underwent a rest-stressed PET scan showing moderate anterior ischemia and had continuing chest pain with the initiation of nitrates, beta blocker, and continuation of other medications. And I think that this media will also be blocked, and it is, unfortunately. Patient at that point was considered higher risk based on the anterior ischemia, underwent coronary angiography, not shown here, showing a very good correlation, and that patient was stented with resolution of chest pain. So I know that this has been kind of whirlwind trying to get through all of this, but again, there's been a lot of information, you know, to try to go through this. Obviously, the guidelines are there, along with executive summaries and high yield facts. But really what it comes down to is that the new ACC-AHA guidelines provide recommendations for evaluation of chest pain across the spectrum of patients. And really this is a diagnostic guideline rather than a treatment guideline. That's in contradistinction to the ESC that which we had shown before. But just to remind ourselves, what are some of the new guidance? High sensitivity troponin is preferred, and I think this is something that we should be considering, although rolling this out obviously can be rather difficult, because I think we already have enough troponemia as it is, and we can anticipate that there'll be a lot more as we move more patients from a gray area into a red area. In patients that are considered low risk, that's the less than 1% of MACE, those patients can be discharged with the option to do additional testing later, but this gives us carte blanche to say, patients low risk, we don't have to worry about it, please go home. The suggestion is that we should be using more clinical decision pathways and structured risk assessment. And so fortunately, we have the UW chest pain pathway, which was created and endorsed by multiple people, including a number of people on this call. And if you really want to find it, you can consult Dr. Google. I actually put it on as a quote unquote app on my phone, so I'm able to get to it anytime. And I would suggest that you do this. We need to make this a little less clunky. It's a little clunky, I will say. Make it a little less clunky, but in addition, we also need to have it for stable chest pain. That will be a subject for further development later. For women, always assessing the atypical and also the accompanying symptoms. And then now trying to get away from this moniker of atypical, call it possible or call it non-cardiac. For patients that have known coronary disease or intermediate risk, CCTA evaluation is actually highest level of evidence, highest level of recommendation now. So it's finally getting its due, and this really now aligns with both the European Society of Cardiology, the NICE in the UK, and now the Americans, that this should be considered. And just knowing that few patients are high risk, but those patients really should not find their way to a CT scan, or they should find their way to something else. Guidelines-based medical therapy is really underlying all of this, whether or not it's in the pathway or not, and really thinking about whether or not we should be risk stratifying and then using either aspirin or statin for those primary plus or secondary minus patients. And then of course, using anti-anginals, and then failing anti-anginals, those patients go to invasive coronary angiography based on these guidelines. If we do stress testing, we should really be doing stress modality based on expertise and availability, and then using a guideline in order to figure out what would be most appropriate for our patients. But we can also use FFRct if the coronary CTA shows a greater than 50% stenosis. It's additional cost, but no additional radiation, no revisit for the patient. It's something that can be sent out and done. So something reasonable and something that we are looking forward to having here at the University of Washington soon. Remember that we're stratifying by normal and mild to moderate severe as far as further evaluation versus no further evaluation. And based on the guidelines, they have limited the direct line to invasive angiography to high risk. Some of those are featured here, but not all. And so with that, I would like to thank you, and special thanks to people that have helped me review this, gave me some good suggestions, and many people I've worked with over the years to try to develop this. This is an incomplete list, but I'd like to thank those people. And if there are any questions, here is my email. And if there's anything that you didn't like, please email me at ekrieger@uw.edu. So thank you very much. I'd like to take any questions at this point.
We have several questions in the queue here, Kelley. I think I'll direct your attention to a couple of them that I will arbitrarily say are probably the most important. Please clarify the high sensitivity troponin levels. I think the slide stated 0.20, which would be a level of 200 for high sensitivity troponin. I think you meant less than 0.02.
Yeah, I did make that clarification. My apologies for the typo. So I did make that clarification while we were going through. That is correct. It's 0.02. And again, it's just the transfer between standard troponin levels and high sensitivity troponin levels is just multiplying by 1,000.
So we have some very important colleagues that work with us virtually all the time, our nurse practitioners and a nursing support staff. And one of the questions is, can you speak to, I presume this is the American Society of Nurse Clinicians, lack of endorsement to the guidelines? Do you have any information about that, Kel?
Yeah, that's actually the American Society of Nuclear Cardiology, just to
Oh,
clarify.
sorry.
Yeah.
Sorry.
So ASNEC was part of this. Each society actually weighed in on this, and the ASNEC board of directors, even though the reviewers signed off on it, the board of directors decided not to. And I'll tell you why. And of course, that knowing that this was going to be coming, the first reserve slide is this one. And so why did they take a pass? And there were a couple things that they talked about. They thought that the FFRct component was too prominent, and that was actually put into the box with all stress testing, if you remember, because of limited availability, limited efficacy, limited level of adoption, substantial costs, and inconsistent insurance coverage. I put down at the bottom, SPECT had the same problem in the 1980s and 1990s, and guess what? PET still has the same problem, except for efficacy. And for that, which I think actually holds a little bit of water, the diagnostic accuracy is actually somewhat modest, and the specificities are in the 70s. Although, if you look at the incremental benefit in those high-risk patients, it actually goes up and is shown to be statistically significant. So that's true that the overall specificity is actually pretty modest when compared throughout. The diagnostic accuracy is not perfect. It's a test that doesn't require any additional evaluation. You can use the existing cardiac CT. It's a send out. It comes back in a couple of hours. They're doing it now within maximum about 6 hours. Usually it's less than that. But that's something that can be considered, is that it may not be as good as some of the other stress testing, but I think it holds fairly consistently. They talked about that there are small, typically short-term intermediate follow-up trials, but there are prognostic data showing that it actually does really well. Granted, these trials are less than 4 years, but in the initial evaluation, the 1 year, there's actually a reasonable amount of evidence that the patients do well. And so because of this, we believe that the 2A recommendation was actually reasonable due to the randomized controlled trials as well as the incremental accuracy. They were true, and I talked about that they did not differentiate certain patients for certain tests, and all stress tests were lumped. And so there's hashtag patients first, which I think is, yeah, I think all of us do that. But they did endorse, they said, based on patient characteristics, local expertise, and availability, and just didn't go any further. So I think that we'll select that. Now, I think the thing that really holds water is that there can be unintended effects on payers, and we're actually doing a document right now on PET, which is talking about this, and that is that insurers and payers may actually do a financial test substitution. And that is, they'll look at this, and we see this all the time where we send for a stress echo and they come back, they say, no, you need to do a stress ECG first. And I think this should be avoided at all costs, because something like SPECT could go to stress echo, and PET could go to something else. There may be a reason why I want to do PET. There may be Minoka patients that I want to do PET. And so I have to jump through my hoops in order to try to do this. And so I think that financial test substitution is really actually something that is really a problem, and that is especially if we're using these clinical decision tools, that should be enough, and we shouldn't have someone with a Excel spreadsheet telling us how to practice medicine.
We are 3 minutes over the hour, and I want to thank the audience for its patience. And please take advantage of the email address that Kelley gave you. If you have, there are several questions that I did not try to address, and I suspect there are many more. So thank you all for your attendance, and Kelley, thank you for a superb dodging and weaving through this very complex set of guidelines.
Thank you, Jeff.
We are adjourned.